I'm not sure of this answer. I will mark and I will check and we can discuss in the next meeting. Because we know that Huntington's disease, chorea is common. There can also be hypertonia, so dystonia can't be there. Now, rigidity and bradykinesia, maybe mostly bradykinesia is the rare presentation, but we'll check it. Next, the question is the growth of head circumference. Head circumference in first 3 months per month. How much growth you expect in head circumference in the first 3 months? This is the question. So we have to remember this. 2 centimeters per month for the first 3 months. That means in the first 3 months, the growth of head circumference should be around 6 centimeters, 2 centimeters per month. Then the next 3 months, it will be 1 centimeter per month. Then in the next 6 months, that is up to 1 year, it will be 0.5 centimeters per month. So total of you in the first 3 months, you will get 6 centimeters. In the next 3 months, you will get 3 centimeters. In the next 6 months, you will get again 3 centimeters. So total of 12 centimeters per year is expected. These such type of questions they are asking. So this is very important. I will repeat it. Head circumference in the first 3 months. Per month, the growth is 2 centimeters. So in the second 3 months, that is 3 to 6 months, it will be 1 centimeter. 2 centimeter per month in the first 3 months. Then in the second 3 months, 1 centimeter per month. So we will have 3 centimeters growth. In the first 3 months, we will have 6 centimeters growth. In the second 3 months, we will have 3 centimeters per growth. Then the next 6 months, we will have 0.5 centimeters per month. That is half centimeter per month. So for over the 6 months, it will go 3 centimeters. So in 1 year, how much growth is expected of head circumference is 12 centimeters. Okay. This is clear. Only one we have doubt is this Huntington's disease. We can check it later. Next. 4 months body weight is 3.5 kg. This is at birth, I think. Now, head circumference is 35 centimeters. Now, it is 47 centimeters. That means how much growth is done? In 4 months, usually we expect 7 centimeters growth of head circumference, right? But here what has happened? 35, 47. There is 12 centimeters growth in 4 months. See, at birth, the head circumference was 35 centimeters. Now 47 centimeters means you're seeing 12 centimeters growth over a period of 4 months, which is too much. For us, normally we can expect 7 centimeters growth. So length at birth is 50 centimeters, now 60 centimeters. So length also, how we should know this? Length 50 means we expect him to be 75 centimeters by 1 year. So no change in sucking since birth. There is also no change in sucking. So there is the 12 centimeters. Now, one clue we have, it's very clear that there is 12 centimeters growth in head circumference, which is too much. That's why you need to check what is the reason for it. They are asking, what do you want to do? Ultrasound, brain MRI, cranial sonar, LP, or congenital infection. So it is brain MRI is the option they have chosen. Maybe this growth is from the hydrocephalus, we don't know. So they might need to do brain MRI to check what is the reason for this growth.
At the age of 4 months, why not ultrasound brain?
Yeah, but you know, you mean you want to see from the region of anterior fontanelle? I think the anterior fontanelle can be act through the ultrasound through the anterior fontanelle can be accessed very well in the early months. Uh, uh, as the baby will grow, the fontanelle will go small, right? I
Mhm.
don't think there will
Yes.
be a clear access. This is why we should check. The ultrasound is indicated until what age? Cranial ultrasound in children. Let me just check quickly and come. Let's see, I will read for you. Cranial ultrasound is an extremely valuable tool for evaluation of brain during first year of life. It is used to look for hemorrhage or hypoxic ischemic event in the neonate to exclude and monitor hydrocephalus and brain malformations. So I don't know. There is a confusion now. And also in 4 months
I
age,
think
yeah,
there might be like um, uh, saber gigantism or something like this. For that, we have to do MRI brain or any
and
tumor because the child
yeah,
is growing very fast. The height is also growing, head circumference is also growing fast.
yeah, head circumference here, he has given almost 12 centimeters here, the growth
Yes.
in 4 months. And height is 10
Mhm.
centimeters in 4 months. And he's no change in
Mhm.
sucking since birth. So, we don't know. Can be ultrasound also because here I will share the screenshot what I read and also the
Mhm.
reference from where it is given. Uh, uh, but in normal practice, what do we do? Even if we do ultrasound first, if we don't know, we will go for MRI, right? Directly, usually people are not going for MRI. But because this age 4 months, it is not easy to do MRI also. The child will not stay for 20 minutes in the machine with those sounds and all. We know the sounds of MRI, how they do. So, don't know. We have to ask uh, or check some other source. Maybe in Naja notes also this question is there. I don't know what answer is given, but normally up to 1 year of age, we can do cranial ultrasound. Okay. And maybe this is brain MRI. They want to know if there is any tumor or there is a blockage in the uh, this ventricles, which is causing rapid accumulation of fluid and hydrocephalus. We don't know why there is so much of rapid growth. So that's why they are considering brain MRI. Anyways, there is confusion here. This cranial sonar or brain MRI. We have to check this. Okay. Whatever is clear is clear. Some answers which are unclear, I am taking the pictures of it to check from other sources. Okay.
Okay.
Okay. And next is the one more question which was confusion for us is this Huntington's disease. Do you think the rare clinical presentation is chorea here? I
No,
think,
I don't think so.
yeah,
Korea is the like
chorea is the
is
common.
the
So it
common usual presentation.
yeah, before we read here somewhere that hypertonia can be the presentation. So we can consider dystonia here also as its presentation. So rare can be either bradykinesia or rigidity, right? What about
Mhm.
rigidity? Do you see in Korea rigidity and
I'm
bradykinesia?
not.
I don't think the child with Korea they are not they are they are mobile. Bradykinesia also it can be a rare presentation. I'm telling you. It is not a common presentation, but I don't know. Some questions are really confusing. This and this. We will try to check these two questions. Next is the IV dexamethasone is used in the meningitis due to which organism? We read it before also. H influenza type B. This is clear question. Next, other options is Streptococcus pneumoniae, meningococcal meningitis, Listeria monocytosis, and fungal meningitis. So we are using most commonly in H influenza type B meningitis, dexamethasone. Next is enlargement of the head in a 2 years old child could be due to. Okay, we see large head, macrocephaly in what conditions? We have to go on thinking now. Yes, hydrocephalus. They have written cephaly, but I think it is cephalus. So hydrocephalus, yes, there will be large head. Megalocephaly, that means big head. That means it will be there. Rickets also usually we see big head. Chronic anemia, I don't know about it. But congenital rubella, usually we see microcephaly. So the answer here is congenital rubella syndrome. Next is the first line medications for status epilepticus include all of the following except. So we usually consider rectal diazepam, yes. If not, intravenous lorazepam, yes. And also if these two fail, next we go for intravenous fosphenytoin or intravenous phenobarbital. But I have never heard of intravenous valproic acid, right? I don't think there is
Yes.
intravenous valproic. So this is the answer. Next is 10-year-old boy sustained 30% BSA burns and had been requiring dressing changes for physical therapy. So he has 30% body surface area burns and he's 10-year-old boy. Which of the following regimens will provide best pain management? IV morphine bolus, oral ibuprofen, oral acetaminophen, oral morphine, and oral lorazepam. There is oral morphine. I don't know about it. Have you heard about this oral morphine?
I think um, yes, oral morphine also is a choice, but here it is written IV morphine.
IV morphine bowl. No, you can see there is also IV morphine, oral ibuprofen, oral morphine, and oral lorazepam. Why they will give lorazepam? Just to calm him?
No, 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 no. In the reducing the pain of burn, we use morphine, either IV, either oral or intranasal. Only like morphine is usually used to reduce the pain in case of burn.
Yeah, I agree with you.
Ibuprofen, acetaminophen, yeah, these are of no use.
But
Even morphine can be given intranasal in case of burn.
yeah, I agree with you. But why he has given oral lorazepam? I don't think this is the
No,
correct
no.
answer.
What's the use of oral lorazepam? No.
And even I think the lorazepam comes as IV preparation, right? There is also oral.
Not sure. Oral morphine and oral
Usually in
lorazepam.
seizure,
I don't have.
in controlling epilepsy, we are giving oral
Hmm.
lorazepam, right? So
Hmm.
I don't think this is
But
the
lorazepam also available IV.
yeah, lorazepam is available. He has given oral lorazepam here. Had been requiring dressing changes for physical therapy. Which of the following regimens would provide best? I think IV morphine bolus is the best in.
But one thing. Now I get one point. Like we do not recommend a bolus for morphine.
Hmm. It should be given over
Is it? Like it over a certain period of time,
30
because it may
minutes.
cause respiratory depression
Yeah,
if we
yeah.
give a bolus
That's
form.
what I'm telling
So I
you.
think,
Over 30
uh,
minutes or 15 to 20 minutes,
uh,
like
yes.
so
So I think this then oral morphine is the best option.
maybe this lorazepam here can be to calm the child.
Mm.
Like we use no
Yes.
sometimes
Yes.
midazolam to sedate and calm the child. Uh, this can be the reason they are using. So no, we should know why this option has been chosen. Bolus,
Yes.
as you
And
said,
if the option A option, if the bolus is not there, only IV morphine, then this is best option, IV morphine. But the bolus, no, I don't think.
because
Bolus,
yeah, because as you said, it will cause respiratory depression, right?
yes,
So I think this is the reason.
yes.
For me, oral morphine is to control the pain. Oral lorazepam is to calm the anxious because anyone in burn pain will be anxious. They need
Mm-hmm.
something to calm,
Yes,
maybe to sedate or to calm like this. Maybe this is the reason. Oral morphine and oral lorazepam.
yes,
Okay. Next, a burn wound characterized by absence of painful sensation means there is no pain in the burn.
hmm.
Absence of painful sensation, bleeding or capillary refill. The best is classified. Obviously, it will be first degree, no, moderate to severe, second degree, no, mid level, full thickness burn. Usually, full thickness burn, even the nerves will get burned.
Yes, because
So
the
we don't have
yes,
pain, and also the blood, the even the arteries and venules would have been burned. So you don't see any painful sensation, bleeding, or capillary refilling.
hmm.
Full thickness burn. 4 years child come with fever. 4 years child come with fever, rash all over body. Fever with rash, irritable, vomiting. He looks ill. Okay, fever with rash, irritable and vomiting. He looks ill. What investigation you will do? Definitely we will do CBC, CRP, blood culture, and also if we suspect the features of meningitis, we will consider LP. But at the moment, the first preference will be blood culture, right? Before going to
Yes,
LP or CT, because here he has given
hmm.
fever, rash, irritable, vomiting. Now, to start with, we will start with the basic workup, CBC, CRP, blood culture. Then we will go for LP if we are suspecting meningitis or encephalitis, and also CT. So he has chosen blood culture here. Features of acutely raised intracranial pressure. Raised intracranial pressure include all of the following. Tachy, uh, all of the following except. So raised intracranial pressure, we see papilledema S. It can cause convulsion S. There can be squint, yes. Raised blood pressure and bradycardia will be there, right? We call it as Cushing's triad.
Yes,
Bradycardia, increased blood pressure, and what else is that it comes in triad?
papilledema.
Hmm. So here they are all,
I think the third one is small breathing, deep sighing respiration.
yeah.
In case of raised intracranial pressure, the patient will have bradycardia and this deep sighing respiration is also there.
Cushing, yeah, you're right. So Cushing's triad is considered of uh, widened pulse pressure, that is increased systolic and decreasing diastolic, bradycardia and irregular respirations.
Yes,
Triad
this
in
is triad.
uh, raised intracranial pressure. This is, see, respiratory suppression, bradycardia and hypertension. So the tachycardia we don't see here.
Yes,
So this is the right answer.
no, yes,
The question here is, we have to be careful sometimes when reading the question. The question here, what he is asking, all are the features of acutely raised
Yes.
pressure except, means he is asking what you don't see in it. So we see papilledema, we see convulsion, we see a squint, we see increased pressure, but we don't see tachycardia. Next is white reflex pupil in the left eye of newborn. So white reflex in the newborn, you
Hmm.
clear it is retinoblastoma. Congenital cataract
Yes.
can present but not in single eye. Usually it will be in both eyes. Galactosemia also in both the eyes. Lens dislocation, I don't think it will produce white reflex pupil. So white reflex is usually retinoblastoma. This is correct. Now, Wernicke-Hoffmann disease, all true, except Wernicke, then is a mild form of poliomyelitis. This is wrong. It's not poliomyelitis. It is autosomal recessive disorder. So, fasciculation of tongue is a recognized clinical finding. This is correct. The main pathology is in the anterior horn cell. This is also correct. It is classified as type 1 spinal muscular atrophy. This is also correct. So, the wrong is a mild form of poliomyelitis.
Hmm.
Next is most common complication of cerebral palsy. So we will read all the options and then decide over. Sensory neural hearing loss, epilepsy, microcephaly, mental retardation. So what is the most common complication? Is it sensory neural hearing loss?
Why sensory neural hearing loss? It's only related with connectors. If the child is having cerebral palsy due to hyperbilirubinemia in the early days of life, then they have sensory neural hearing loss. Otherwise, I don't think so.
Yeah, commonly they have epilepsy. We see more epilepsy and also mental retardation.
No, 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 not usually. Mental retardation is usually with the quadriplegic cerebral palsy. The diplegic cerebral palsy, they have intact mentation, and
I know. So
it's not
I
necessary that every cerebral palsy has epilepsy.
microcephaly.
Microcephaly, yes, yes,
Mm. So we
yes,
have
they
to
are microcephalic.
most of them,
I think
almost all.
microcephaly is the more common sign. Most of them,
Most
yeah,
common
they are
complication of
microcephalic.
cerebral palsy. I don't think sensory neural hearing loss, as you said. You said it is most commonly seen.
Sensory neural hearing loss can be, but only with the condition if the infant neonate has hyperbilirubinemia
That's what I'm telling.
causing connectors. Then they, hmm,
Yeah, that's what I'm telling. It can be, but it is not the question here is common. All are here can be. Like, for example, sensory neural hearing loss
hmm,
in carnivorous. Epilepsy can be in most of them. Mental retardation again
yes,
in patients with carnivorous. But microcephaly will also be in all. But which among all these four,
hmm,
which is the most common complication? I go with microcephaly because usually I think everyone's head is small. The second, I
yes.
go with epilepsy after microcephaly if we have an option. Okay, but see, some questions are confusing like this. You don't know what to choose.
I will also check it.
Yeah, you have to check these questions. A child has convulsion, now stopped. Child has convulsions, now stopped. No signs of meningeal irritation. Negative Brudzinski's and Kernick's. Anterior fontanelle at level. What will you do next? EEG for diagnosis of epilepsy. EEG for febrile convulsions. CT for intracranial infection and focal mosses. LP. See, he is telling there is no fever. Children with first seizure in absence of fever, as recommended by American Academy of Neurology, EEG. Here, no signs of meningeal irritation. Negative Bruce
Yes.
and anterior fontanelle is not bulging, it is at level. So definitely I will not go for all these things for intracranial infection and focal mosses
Yes.
and also LP. So I will think this might be a presentation of epilepsy and I will go for EEG. And no one is doing EEG for febrile convulsion.
Yes.
EEG for febrile convulsion is not there. No one will do that. So LP is not an option because there is no signs of infection. CT is also not an option. So EEG for epilepsy. The explanation here is children with their first seizure in absence of fever as recommended by American Academy will go for EEG. Child after complete control of an attack of seizure in ER. Child after complete control of an attack of seizure in ER, all labs normal, no septic focus, negative Brudzinski sign. Again, no septic focus. All labs normal, no features of meningitis. So again, you'll go for EEG for epilepsy. We are not doing EEG for febrile convulsion. LP is not done because no suspicion of infection. Breath holding attack. Precipitate factor for generalized convulsion associated with increased incidence of epilepsy in late life. This is wrong. Breath holding attack is not associated with increased incidence of epilepsy. Common in children between 5 to 10 years? No.
No.
Less than 5 years. Right.
Mhm.
So
Yes.
there will be some precipitating factor which will cause the child the reflex anoxic seizure or breath holding attack. That is the correct answer.
Yes.
What increase the incidence of epilepsy? What increase? Typical seizure, first febrile seizure after 9 months, patient with status epilepsy. No, no, these two options only is given. If a child is presenting to you in a typical form of seizure always, that means there is increased incidence of epilepsy in him, not in first febrile seizure at the age of 9 months, right?
Mhm.
So this is the correct
Yes.
answer. If he is presenting you repeatedly with a typical type of seizure. Again, this cryptogenic epilepsy came. Patient with status epilepticus, which is not common cause. Not common cause in children is cryptogenic epilepsy, 14%. That is refractory epilepsy without knowing any cause is cryptogenic epilepsy. Cryptogenic epilepsy means you have refractory epilepsy without any cause. Okay. A toddler, 10 months old infant stretches the head, extends arms for a while and back to normal. EEG spike and waves. We know this is infantile spasm, what they are explaining. Stretches the head
Yes.
and extends the arms for a while and back to normal. So, and he's 10 months old. I don't think all the other absent seizures is atonic CP, complex partial seizures. No, infantile spasm is the correct answer. So we'll go to the next. A previously healthy 7-year-old child suddenly complains of headache and fall on the floor. 7-year-old child. When examined in ER, he is lethargic with left central facial weakness and left hemiparesis and conjugate ocular deviation to the right. So he has left-sided facial weakness with left hemiparesis and conjugate ocular deviation to the right. So what is the diagnosis? What is infantile hemiplegia? I don't know this. I think here we have to search for the answer, correct answer.
This is quite new term for me, acute infantile.
You have, if it is from the hemiplegia due to this internal capsule. If you have left-sided hemiplegia, you'll have right-sided facial weakness, right? Or same side. I think we have to check. I don't think this is the correct answer. Why infantile? He is 7 years old. This is one thing. And we will check this answer. I will take the picture of it. Tomorrow, whenever we are free, whatever answers we are in doubt, we have to check back with someone who has taken before or from any source. Next, worse prognosis for neuroblastoma. Less than 1 year, more than 1 year. Increased urinary catecholamine, hemihypertrophy. So for neuroblastoma, which is more than 1 year old, is worse prognosis. I think there is some few points about who has worse prognosis in neuroblastoma. I will check that and send the screenshot, okay, after this meeting.
Okay.
So I will go. These two questions are pending. 6 years old child presents with straddling gait and inability to stand or walk without support. Straddling gait, inability to stand or walk without support. He is irritable with vomiting 3 times. He has history of chicken pox 3 weeks ago. On examination, all are normal except resistance when trying to flex the neck. This means what is the most likely diagnosis? Meningoencephalitis. This is resistance when trying to flex the neck means what? Neck rigidity, right?
Yes, neck
Going
rigidity is there.
mainly feature of meningitis. So, see, what is the positive point here? Straddling gait, inability to stand or walk without support, irritable, vomiting is also there. That means raised ICP. Chicken pox 3 weeks ago. Resistance when trying to, all are normal except they have not told ataxia here. So meningoencephalitis. Dolichocephaly, scaphocephaly is association with craniostenosis is due to premature closure of sagittal suture. Dolichocephaly is due to premature closure of sagittal suture. This is some extra point he has given. Okay, you are performing a well child examination on a new patient. The 1-year-old child shown in the picture with left eye squint. Your next action should be, so 1-year-old child with left eye squint, what will be your next action? Patch the eye with greater refractive error. Patch the eye that deviates. Defer patching or ophthalmologic exam until the child is older and better able to reassure the mother he will outgrow. Refer immediately to ophthalmology as central vision may fail to develop if the diagnosis and treatment are delayed. This is correct. Because his age is already 1 year old. There is some picture they have shown there with left eye squint. Okay. Again, brain myelination start 0 to 6 months, more at 6 to 12 months. Okay, so I will end now. Maybe we will join just to read another 1 page and stop so that we'll finish at least 5 pages today. Okay.
Okay.